Welcome to Persyst Grand Rounds, an online series of lectures hosted by Persyst, covering topics related to advanced EEG analysis for improving outcomes in both neurocritical care and epilepsy monitoring environments. I'm Marie Carroll, and I'm the Director of Product Management with Persyst, and I'm here to introduce our speaker and topic for today's Persyst Grand Rounds. Next slide, please. Through our customers, we understand the importance of investing in the EEG community through education, where expertise and knowledge can grow towards the utilization and implementation of EEG and quantitative EEG. The goal of Persyst Grand Rounds is to provide a platform for those with clinical expertise on topics of advanced EEG analysis as a way to connect with a broader community to share their experience and knowledge so that we can all learn and grow together. Each online lecture features an experienced epileptologist or neurophysiologist presenting on a topic of their choice as it relates to EEG monitoring and analysis. And you can visit www.persyst.com/grandrounds to keep up with the schedule. Next slide, please. The opinions and viewpoints of each speaker are solely their own and do not represent Persyst or any other commercial entity or commercial interest. Speakers are not required to include Persyst, its software, products, or services. The content presented was not prepared or edited by Persyst. Persyst is not providing any form of compensation. And finally, what we've been waiting for. So there will be time for questions after the talk. You can write your questions in the QA box, which you'll find at the bottom of your screen. And there will be a recording of this webinar, which will be shared afterwards. Okay, and so now what we've all been waiting for, I want to welcome our speaker today, Dr. Ramya Raghupathi, Assistant Professor of Clinical Neurology at the University of Pennsylvania Perelman School of Medicine. And today, Dr. Raghupathi will speak on updates in epilepsy surgery and neuromodulation. The learning objectives are to provide a concise overview of drug-resistant epilepsy, including its definition, to identify treatment gaps, and to review trends and updates in epilepsy surgery, including neuromodulation over the years. Dr. Ramya Raghupathi is to the Department of Neurology, is an Assistant Professor of Neurology at the Hospital of University of Pennsylvania. She completed her residency in neurology at the Albert Einstein Medical Center in Philadelphia, Pennsylvania, where she was chief resident in her last year. Following her residency, she completed a fellowship in epilepsy at Cleveland Clinic in Cleveland, Ohio. She spent a second year there to focus on the surgical management of patients with refractory epilepsy. Dr. Raghupathi also served as faculty for a year at the Cleveland Clinic, Florida. Dr. Raghupathi is board certified in neurology and epilepsy. She has presented multiple times at the annual meeting of the American Epilepsy Society and American Clinical Neurophysiological Society. Her primary interests are in surgical evaluation of epilepsy patients and post-surgical outcomes. In addition to her inpatient and outpatient care of patients with epilepsy, Dr. Raghupathi is active in the area of fellow and resident education and participates in frequent teaching conferences. In addition, she's also the interim ICU and EEG lab director at the Hospital of the University of Pennsylvania. So without further ado, I present to you Dr. Raghupathi.
Thanks, Marie. Thanks for that kind introduction. So I'll get started. I'm using two different screens. I'm just going to turn my video off while I do this. Okay, hopefully everybody can hear me well as I go through this, but if you don't, just feel free to shout out or raise your hand. All right, so my talk today is discussing updates in epilepsy surgery and neuromodulation. This topic is very vast and intricate. The hope with the presentation is to provide a balanced overview of the literature, highlighting both the successes and challenges in epilepsy surgery and neuromodulation. I have no disclosures. The objective of the talk was alluded to, is to provide a concise overview of drug-resistant epilepsy. We'll look at some treatment gaps and look at the evolution of surgery and minimally invasive options for its management in epilepsy. I'll touch upon some key studies and advancements that have been used in laser interstitial thermal therapy, which I'll refer to as LIT going forward, focused ultrasound, quick couple of words, and then radiofrequency ablation. And we'll also delve into some expanding applications of neuromodulation in the treatment of epilepsy. Now, epilepsy is a significant global health concern. Like, it affects millions of people worldwide, 3 million in the United States alone, and has a pretty substantial economic burden. There's an estimated $10 billion annually in the United States itself. Now, our subset of patients face unique challenges. It's not just the physical and emotional toll, but it also leads to like injuries and even death in our patients. Like SUDEP is a significant concern. The mortality is usually 11 times higher compared to our general population. The unpredictable nature of seizures can also limit an individual's ability to drive, maintain employment, which also leads to significant disruptions in their daily lives. So addressing this comprehensive need for individuals is crucial. So it not only just includes managing seizures, but also providing support for like psychological well-being, optimizing their quality of life, promoting inclusion and participation in society, and improving access to effective treatments, increasing awareness. All of this kind of helps in order to address the comprehensive evaluation of this multifaceted disease. Now, drug resistance, also called pharmacoresistance, it refers to the phenomenon where a patient's response to drug diminishes over time, resulting in the medications becoming less and less effective in treating a particular condition or disease. Now, in the context of anti-seizure medication, there's a lot of factors that can contribute to drug resistance. Individual patient characteristics, genetic predisposition, the underlying disease progression and the complexity of the disease itself, and of course, the interplay between multiple medications or drug interactions can also contribute to this. Now, we've all seen some versions of this graph at some point. Now, the biggest takeaway from this is like, despite the development of new medications and advancements in the field of epilepsy, Quantum Brody's work emphasizes the challenges we typically encounter in our clinical practice. They've shed light on the fact that some patients with epilepsy or seizure disorders may experience a diminishing response to seizure medications, making it more and more difficult to manage this condition effectively. It's a reminder that while new medications are being developed, understanding and addressing drug resistance remains crucial in treating these patients. Now, for individuals with drug-resistant epilepsy, there's other non-medical options. They encompass a range of approaches. They include brain surgery, minimally invasive techniques, there's neuromodulation, there's dietary approaches, and there's certain other options that are also being studied, including like transcranial magnetic stimulation or direct stimulation. For the purpose of this talk, we're going to stick primarily with laser interstitial thermal therapies, radiofrequency ablation, and ultrasound, and neuromodulation predominantly. I would like to start by driving home this point. I think it's important to acknowledge that surgical treatment for epilepsies like anterior temporal lobectomies and selective amygdala hippocampeectomies have shown clear benefits or like superior outcomes in compared to medical management. There is high-level evidence from randomized controlled trials and meta-analysis that have validated and supported these favorable outcomes. ATL serum fetal rates approximately 72%, slightly less in your selective amygdala hippocampeectomies, around the 60-65% of Angle 1 outcomes. But in any case, there is a clearly demonstrated difference between surgical and medical groups, suggesting that surgery not only reduces seizures, but also has the potential to enhance the quality of life for these patients. Now, research also indicates that healthcare costs tend to decline in the long-term follow-up following epilepsy surgeries. There's, the individuals who undergo surgery have a low direct medical care cost and reduced healthcare utilization in the years following surgery compared to matched controls who did not have surgery. When you look at it from a payer perspective, the initial cost of surgery may actually be offset by future savings within a relatively short period of time. This means that the long-term benefits of surgery, including improved seizure control, reduced reliance on medications, will eventually result in cost savings for healthcare payers. But surgery as an option is often underutilized, despite an increase in hospitalizations for epilepsy-related issues. There's actually a significant gap between the number of potential surgical candidates for epilepsy and the number of surgeries that are actually performed. The literature here is based on like a prevalence database from CDC. It kind of highlights a considerable pool of potential candidates for surgery who are not being referred for surgical evaluation and thereby missing out on the opportunity for like improved seizure control and quality of life. There's a lot of factors that contribute to this. Clearly, physicians' knowledge, lack of coordinated care, misconceptions about surgery, and some socioeconomic disparities can hinder access to care. But there's also a lot of efforts that are being made to address this gap and increase access to surgery for appropriate candidates, like improving awareness and education about surgery among healthcare professionals and patients, implementing a standardized referral process, enhancing more of a multidisciplinary collaboration, and advocating for resources and funding to support evaluation and interventions. And finally, there's also like a shift towards these minimally invasive options. Now, this shift reflects the ongoing efforts to improve surgical outcomes and patient experiences while preserving your cognitive and functional abilities. Now, while traditional surgeries remain an essential component of epilepsy surgery, the emergence of these minimally invasive options have expanded the range of treatment possibilities for patients. It is important to consider that every patient is unique. Their circumstances and preferences are unique. What may be considered optimal for one person might not be the same for the other. So the decision-making process should actually involve a comprehensive evaluation of various treatment options, taking into account all the factors like the underlying cost of epilepsy, patient's medical history, and clearly their own preferences and values. Now, minimally invasive approaches offer several advantages over traditional open surgeries. They're smaller incisions, they reduce tissue trauma, shorter hospital stays, faster recovery time. All of these kind of make it more palatable to the patient while also like maintaining significant they're also significant in terms of their seizure outcomes, satisfaction, and overall quality of life. Right. So starting with LIT, like laser interstitial thermal therapy, and like I said, I'll refer to as LIT going forward. It has its root in neurosurgery. It was initially explored as a technique for ablation of brain tumors. The use of laser energy to precisely heat and destroy targeted tissues proved effective in tumor ablation, which eventually led to its exploration for other neurological conditions. In 2007, FDA granted approval for LIT for epilepsy surgery, marking an important milestone, making this a viable treatment option for epilepsy. Now, LIT has been primarily used for the treatment of mesial temporal lobe epilepsies, which is the most common form, but it's also been applied to other focal epilepsy syndromes and lesional epilepsies, which we'll take a look at as I go through the presentation. The safety and efficacy of LIT for mesial temporal lobe epilepsies has been established and validated in several studies since the initial publication from Dr. Gross. Overall, there's been similar results across several earlier literatures and case series, with seizure freedom rate averaging into 60% at 1 year, slightly less than open ATL, and slightly higher in the lesional compared to the non-lesional patients. To the right is one of the initial prospective case series that looked at 13 mesial temporal epilepsy patients with and without evidence of mesial temporal sclerosis who underwent LIT to the amygdala hippocampal regions. 54 of these patients were seizure-free at their 1 year follow-up, and nearly 30% of these patients were completely seizure-free with an Engel class 1 outcomes. And when you looked at patients who with evidence of MTS, there was a higher, much higher, nearly 67% of these patients achieving your Engel class 1 follow-up. This is data from 2 meta-analysis series that's 2 years apart, again, showing similar rates and overall seizure freedom rates. The first one from the Mayo Group comparing laser versus stereotactic radiosurgery. And the second one, also from the Mayo Group, which looked, the study actually included the meta-analysis included a study looking at visual field deficits in patients and reported a nearly 30% rate of like transient deficits in patients after laser interstitial thermal therapy. These rates were higher on the left side after the procedure, but when you compare it to like open resections with temporal lobectomies or like selective amygdala hippocampectomies, this was way less, again, overall, driving the point that there's lesser complications or there are more transient complications with LIT rather than with open resections. Now, LIT clearly has its advantages over ATL when you're considering surgical morbidity. Post-op pain, length of hospital stay, recovery period is usually short, and there's usually return to like baseline activities, including work, relatively sooner compared to open brain surgeries. But one of the biggest outcome measures with LIT is verbal learning and memory performance was minimally affected after these procedures, and there's usually preservation of contextual memory. Several studies have demonstrated the preservation of these functions following in LIT. And in some cases, there's also noted to be an improvement on the non-dominant side, as opposed to a significantly high decline in one or more of these measures, like naming on the dominant or like object recognition on the non-dominant side with standard resections. So this was one of the papers from the Emory group, Dan Drain, What I wanted to highlight from this graph is anything above the line shows an improvement, anything below the line shows a decline. When you look at non-dominant selective intervention with laser, there seems to be an improvement in verbal learning scores and delayed recall compared to open resections on the dominant side when you actually see a huge decline post-surgery. In reviewing patients with pathology, that is patients with MRI evidence of hippocampal sclerosis, with or without hippocampal sclerosis, some of the older studies have suggested that there didn't seem to be a difference in surgical outcomes. So there's several studies out there, but I've just highlighted one where it looked at 30 patients who had MRI evidence of mesial temporal sclerosis, and 12 patients did not, but both these patients were proven on stereo EEG to be mesial temporal lobe epilepsy. You can see that the seizure freedom rates is pretty similar in both these groups, and there was no significant difference with or without the presence of hippocampal sclerosis in imaging. Again, I think what it drives to say is that if you have a carefully selected subset of patients, even without radiographic evidence of mesial temporal sclerosis, laser interstitial thermal therapy can be a reasonable first option to offer these patients. This is a retrospective analysis, probably the largest series to date. It had about 234 patients with long-term follow-up of seizure outcomes after LIT. Again, promising results. Among the cohort, 58% of these patients had Engel class 1 outcomes. Importantly, I think the paper highlighted that these positive outcome measures persisted at a 2-year follow-up, again, indicating the durability of this procedure as a therapeutic option for patients with mesial temporal epilepsies. Now, when you look at the 6-month cohort, the graph to your left, that looked at hippocampal sclerosis subgroup and non-hippocampal sclerosis subgroup, the surgical outcomes were somewhat similar. Again, they found no significant association between radiographic evidence of sclerosis and predicting outcomes after LIT for mesial temporal lobe epilepsies. One of the other important things the study highlighted was the importance of targeting more anterior and smaller temporal structures during LIT, which includes ablation of specific areas like amygdala, the hippocampal head, parahippocampal gyrus, and entorhinal cortices. All of these findings suggest that prioritizing ablation of these regions were associated with better Engel class 1 outcomes. So when you look at the graph to the left, the picture to the left, they've highlighted 2 different regions. One is a theoretically favorable ablation, which is shown in the green, and an unfavorable ablation, which is shown in the red circle. Both ablations are roughly the same volume, but they are located and oriented differently within the mesial temporal structures. And clearly, the one in the green was more of a favorable ablation involving the amygdala, hippocampus, parahippocampal gyrus, and the entorhinal cortices. Now, when you look at the effect of surgical targeting, there's also studies that have demonstrated like a 2-trajectory approach was superior to the 1-trajectory approach in achieving complete ablation of all the hippocampal subfields and amygdala nucleus. This was looked at in a small cohort of 11 patients. I think 5 of the patients in this study at their 1-year follow-ups had good Engel 1 outcomes, and I believe the 6 also showed a positive trend in that direction as well. But again, I think we need like longer term follow-ups and larger patient sample sizes to kind of further validate the clinical outcomes of this technique. We haven't started incorporating this in our centers, but I'd love to know if people on the call or other centers have experience of this and what their surgical outcomes have looked like. All right, so there is limited knowledge regarding the sustained effects of laser treatment over time. Now, this is results from a retrospective analysis that looked at 575 patients. The primary aim of this was to see, again, to look at the efficacy of LIT over a prolonged period of time and to identify if there were any potential effect modifiers. Overall efficacy, again, was found to be in that 54% range. Median seizure-free period was 60% at the 1 year, but at 2 years, the trend seemed to decline, but this trend did not reach statistical significance in the published data. Identifying patients who are more likely to benefit from laser in the treatment of mesial temporal epilepsy is an important consideration for optimizing patient selection and treatment outcomes. Now, in an attempt to address these uncertainties surrounding the sustained effect of laser treatment or selective laser amygdala hippocampectomy, the use of intracranial biomarkers have been explored. Now, this is a retrospective review of about 58 patients where our center was involved with 5 other centers, including Columbia, where we looked at patients with mesial temporal lobe epilepsies with and without MTS who underwent stereotactic laser amygdala hippocampectomy after a stereo EEG was conducted. The primary outcomes were stratified on some seizure onset patterns. Overall, 1, 2, and 3-year Engel seizure-free probability was similar to the retrospective analysis, showing a decline. We had more like 36 to 40% at the end of 2 years, and then 33% at the end of 3 years. Patients with certain seizure onset patterns, like low voltage fast activity or low frequency repetitive spiking, had a 40% probability of being seizure-free at 2 years, compared to 0% of patients with the alpha or theta frequency repetitive spiking or the theta or delta frequency spiking. These findings suggest that some seizure onset patterns can help identify patients who are more likely to benefit from a selective laser amygdala hippocampectomy. There were clearly limitations with the study. The study was underpowered for detection of like smaller subgroup effects or assessing each seizure onset pattern independently. And we've also seen that surgical technique and ablation targets also play a role in the outcomes. And this study did not perform qualitative analysis of ablation structure and volumes. So clearly, further research is needed to better understand the long-term effectiveness of LIT. And one such study is ongoing, which is the SLATE trial, which is a prospective single-arm multi-center study evaluating the safety and efficacy of LIT for temporal lobe epilepsy, and hopefully will provide valuable insights into its outcome and potential applications in different patient populations. Several studies have also investigated the effectiveness of LIT in the treatment of extratemporal lobe epilepsies, albeit smaller numbers. This is a retrospective review from Emory that had 35 patients, of which 32 of them had more than a 12-month follow-up. And reported the 53% of this cohort had Engel class 1 outcomes at their follow-up at 1 year. There were a few subgroup analyses that were done. These subgroup analyses revealed that patients with lesional extratemporal lobe epilepsies did better compared to those without lesions, or those who had multifocal epilepsies, or those who had previously failed interventions. And again, alluding to some favorable seizure onset patterns that we looked at previously, low voltage fast activity or rhythmic spiking on stereo EEG also had a higher predisposition to having better seizure outcomes. Overall, I think this was deemed as a safe and effective treatment for this heterogeneous group of patients with extratemporal lobe epilepsies. The use of LIT has expanded beyond its initial applications and is now being explored in other indications as well. The literature on this is very variable. I think it includes a lot of studies ranging from individual case reports to larger case series, exploring the use in several different pathologies like low-grade tumors, cortical dysplasias, hypothalamic hamartomas, heterotopias, cavernous malformation. I think this could be a grand run in itself. I haven't gone into the details of it, but I'm happy to share the literature to anyone who's interested. But really quickly, a quick word on a comprehensive meta-analysis series that I came across that looked at 46 studies involving 450 patients, again, reporting overall seizure freedom rates in the 50 to 60% mark. And these patients had an average follow-up of at least 12 to 15 months. What they found was that LIT was effective in patients who had well-circumscribed lesions, like your cavernous malformation or mesial temporal sclerosis, and it was less effective in non-lesional cases or cases which had a more diffuse epileptogenic network or associated with generalized seizures. Some of the positive predictors were obviously the presence of a lesion, and poor predictors were non-lesional MRI or generalized seizure semiology had a faster time to seizure recurrence following laser interstitial thermal therapy. All right, quick word on radiofrequency ablation. This is a minimally invasive procedure that uses heat generated by radiofrequency waves to destroy or ablate your targeted tissues. It's widely used in other medical fields like cardiology and pain management, but its application in epilepsy is relatively limited. So radiofrequency ablation basically establishes a current flow between two electrodes for heat induction. And during the procedure, there's a thin needle that's needle electrode that's inserted into the brain tissue, guided by imaging technique. Once the electrode is properly positioned, radiofrequency waves are applied through the electrode, generating heat that destroys your targeted brain tissue. The goal is to eliminate or disrupt the abnormal electrical activity that can trigger a seizure. The suitability of the procedure, of course, depends on several factors, including the specific type, the location of the epileptic focus. The main takeaways, I guess, based on the current evidence is that it's promising. The safety data seems to be reasonably modest, but further research is required, or like randomized controlled trials, to clearly establish its role in preoperative discussion with patients and their families. Again, most of the literature has looked at patients who've had involving mesial temporal structures with or without involvement of temporal neocortex. SEEG-guided radiofrequency thermocoagulation has also known to show an improvement of nearly 50% of reduction in seizure frequency. It's clearly been around since 2001. The pooled seizure freedom rates may be lower compared to surgical interventions, but the complication risks appear to be low. So some patients have shown a positive response, particularly patients with, it's been known to be beneficial for patients with cortical malformations like nodular heterotopias and focal cortical dysplasias, but clearly further studies are needed to validate these. Focused ultrasound, non-invasive technology, it again shows some promising features. This is where many ultrasound beams are focused on one particular target. Usually you want to have a smaller target size. It's FDA approved for use in tremors, but I found 2 case reports in epilepsy in the use of hypothalamic hamartomas. There's also studies that have looked at it or exploring the possibility of it in targeting regions like the thalamus. I believe there were 2 patients in the first known clinical trial looking at the safety and efficacy of focused ultrasound. Both these patients had reported improvement in their 3, 6, and 12-month seizure freedom rates. But one of the patients did experience a decline in verbal fluency and immediate verbal memory. Again, important to note, in the absence of prospective studies, the evidence is still quite low. Now, this is a nice comprehensive review of all of these procedures. The table provides a simplified overview of the results and may not include all the nuances and details of the study. So in this systematic review and meta-analysis, the authors compared outcomes and complications of 3 treatment approaches. One is the MRI-guided LIT, radiofrequency ablation, and conventional surgical approaches like your traditional temporal lobectomies or selective amygdala hypocampectomies. They had about 43 studies. The bulk of the patients were mostly over 1,300 to 1,500 patients were patients in the traditional surgical groups like ATL and your hypocampectomies. There were over 500 patients in the MRI-guided LIT laser group, and just roughly a small number of patients, just over 100 patients in the radiofrequency ablation group. Primary outcome, again, was the measurement of your Engel Class 1 outcomes. Biggest takeaways from this is that there was no significant difference in seizure outcomes between your MRI-guided laser therapy and radiofrequency ablation. Clearly, open surgeries like ATL and selective hypocampectomies were found to be superior in their seizure outcomes compared to your LIT or radiofrequency ablations. Rate of major complication rates were also essentially similar between LIT and radiofrequency ablations, but higher for ATL and selective amygdala hypocampectomies. All procedures were associated with the occurrence of neurophysiological deficits. Left-sided surgeries had a higher rate of verbal memory impairment, but the MRI-guided laser therapy showed a better preservation of lateral functions like naming or object recognition compared to other approaches. All right, so shifting gears, heading into neuromodulation. Neuromodulation is broadly categorized into open and closed loop. Open loop stimulation refers to stimulation where the settings are pre-programmed and they are delivered at fixed intervals or continuously, regardless of the patient's clinical symptoms or the underlying disease state. In other words, the stimulation parameters remain constant and they don't adapt in response to changes in the patient's condition. There's no real-time feedback or adjustments. Closed loop system, on the other hand, is also called as responsive stimulation. It's more of an advanced approach. It has 2 main components. One is the sensing component and the other is the stimulation component. The sensing component continuously monitors relevant physiological signals of brain activity, like ECOGs in the case of the RNS, to detect abnormal patterns or markers which are indicative of an impending seizure. Now, once these patterns or markers are detected, the stimulation component is then activated, and this delivers electrical pulses to disrupt this brain activity, again, aiming to basically prevent the seizure from fully developing or spreading. There's 3 FDA-approved devices. Important to note that all of these devices vary in terms of their targets, their stimulation parameters, and the complexity. But the long-term efficacy for all these devices have generally shown a trend for improvement over time. In terms of the mechanism of action, I think there's several hypotheses that have been proposed. There's somewhat of an overlapping variability between these mechanisms between the devices, but some of the ones include desynchronization of brain activity, there's modulation of neurotransmitter release, there's changes in synaptogenesis and neuroplasticity, and remodeling that is associated with chronic stimulation. To date, there's no head-to-head trials. comparing these devices, and patient selection or the selection is typically driven by like patient characteristics and preferences in addition to physician experience. VNS is the first extracranial, currently the most frequently used neuromodulatory device. It was FDA approved in 1997. Although originally approved for use in 12 years or older, it was subsequently approved for patients 4 years and older in 2017. It's considered to be an open loop system where the device is programmed to deliver your stimulation at a set frequency. It also includes a magnet, which can then be used over the generator to provide for additional stimulation. Now, VNS has evidence for broad spectrum use, generalized and focal and syndromic epilepsies. The effectiveness has been demonstrated in clinical studies and real world experiences. To the left is probably the largest meta-analysis from Dario Englert that looked at 74 clinical studies and reported a 50% reduction after more than 1 year of therapy. Now, long-term studies have reported varying rates of seizure reduction. Some have shown around that 50% mark, and some have reported a higher response rate. Surprisingly, analysis also revealed that patients with generalized epilepsy and children derived more benefits from the therapy, even though they were initially excluded from the device approval. Some of the newer devices like Aspire and the Sentiva have additional features and programming options. So one is that the VNS can be used as a closed loop stimulation in response to relative tachycardia. This means that the device can actually detect changes in your heart rate and provide stimulation in response to these changes, aiming to prevent seizures or reduce their severity. You can have guided programming and scheduled programming, which can be tailored to individual patient parameters, allowing for more of a customized therapy. There's also auto titration. And we also have day-night programming where you can have 2 separate sets of programs that can be customized based on their patient's need during different times of the day or different times of the night. Again, this flexibility allows for a more personalized and effective treatment. In this pediatric study, they looked at the effectiveness of like the traditional VNS open loop and compared it with the closed loop VNS stimulation. There were about 320 patients. 179 of these patients had the traditional open loop VNS, while 41 of these patients had the closed loop VNS. You can see that at 1 year, the response rate to the traditional system was 43%, while the closed loop was 39%. And at 2 years, the difference was a little bit more between the open and the closed loop, but neither of these response rates was statistically significant, which basically means that the study did not find strong evidence to support a clear superiority of the closed loop over traditional in their response after 2 years of treatment. Additionally, I think neither of these groups showed the ability to reduce the quantity of seizure medication also after 2 years. But generalized epilepsy patients overall did better with both traditional open and the closed loop VNS. RNS, moving on to this, it's the only closed loop brain stimulator approved in 2013 to treat medically refractory partial onset seizures. It's a cranially implanted device connected by a combination of 2 4-contact depth or stripped electrodes. Patient selection for RNS has expanded beyond mesial temporal epilepsy. In clinical practice, it's sometimes now utilized in patients with more than 2 seizure foci. Additionally, the RNS system has shown promise in patients where you have unilateral seizures, but overlapping eloquent cortices, where there is a risk to language, motor, or memory functions. I think the flexibility of the lead placements of the RNS also allows for targeting multiple different regions. I haven't shown on this slide, but there was a recent study, which is a multi-center study from Dr. Rao's group from UCSF, which evaluated 30 patients with like a regional neocortical epilepsy, where the leads were just flanking the seizure onset zone, and they did like a lead-to-lead stimulation. What they found in that study was, again, a median reduction of 75% was noted. But importantly, they found that things like interlead distance and charge density did not have an impact on their surgical outcomes. Again, these findings indicate that, RNS system is effective in both for patients, not just medial temporal, but also like regional neocortical epilepsies. There are several major trials that have looked at the safety and efficacy of the RNS system. I think following the initial feasibility trial, the first results of the first multi-center double-blind randomized trial were published in 2011. They had about 191 patients who were either randomized to a treatment or the sham group. After the immediate effect of implantation, which is the white shaded region, the patients in the treatment group showed a trend towards continued improvement, as in a decline in seizure frequencies, but the sham group declined. But when you had the open label period, when both groups received treatment, the seizure frequencies continued to decline. There's two large multi-center studies that demonstrated the safety and efficacy. One is a long-term treatment study that prospectively evaluated patients for 9 years. And the other was the real-world outcome studies, which retrospectively evaluated patients for an average of 2.5 years. Now, at the 9-year mark, the median percentage reduction in seizure frequency was 75%. This also indicates a substantial decrease in seizure occurrence for a majority of patients. They had about 30% of patients in this group who achieved at least 6 months of seizure freedom. And I said the real-world experience was a retrospective chart review of 150 patients from 8 centers. The outcome measures were pretty similar to clinical trials. At 1 year, there was a median seizure reduction of about 67%. Now, similar to long-term outcomes from the pivotal trial, the real world found that patients' age, duration of epilepsy, age of epilepsy onset, seizure onset location, lesional status on MRI, or previous surgeries or intracranial monitoring did not predict the outcomes. One of the biggest advantages we have with the RNS system is the ability to use long-term ECOG recordings, which can provide valuable and quantitative data that can be utilized in various aspects of epilepsy management. So some key areas where this can be helpful is quantitative assessment of seizure frequency. Like you can use this data for a very precise measurement of seizure frequency over an extended period of time, which again, you can use this data to allow for more accurate tracking of seizures and kind of guide your treatment response based on this. It can be helpful for spell characterizations. Clinicians can be able to differentiate between epileptic and non-epileptic events, again, leading to like appropriate diagnosis and treatment decisions. It can also be used for assessing your treatment response to medication and assessing medication effectiveness as well. Behavioral adjustments, also known, by identifying some sort of triggers or patterns with seizure events, you can make informed behavioral changes to potentially reduce the seizure frequency or intensity. Seizure lateralization is huge. I think this information is crucial, and also determining like who would be an ideal resective candidate in the future can also help for guiding your surgical planning, particularly in patients who have like drug-resistant epilepsy. Predicting seizure patterns, again, analyzing this data, it can help clinicians predict the likelihood of future seizures, which can enable proactive managements and interventions to minimize the impact of seizures in patients' lives. So looking at a few of these in detail, I think in patients with bitemporal epilepsy, the ratio of seizures coming from each side plays a crucial role in determining who would be an appropriate surgical candidate, right? And the seizure laterality ratios that we get from our inpatient video EEG monitoring, they don't accurately correlate with those obtained from chronic recordings. Now, one critical example of this is the value of chronic ECOG that comes from mesial temporal lobe epilepsies. We know that sometimes, I think nearly 14% of the times, mesial temporal epilepsies can be a bilateral disease. So this was a study I think everyone's familiar with, which looked at 82 patients where bilateral mesial temporal RNS was implanted, and they were followed for a period of about 4.5 years. The study revealed that the average time it took to record a bilateral independent seizure was about 41 days, and that the presumed lateralization changed in 20% of the patients, as in patients who were previously thought to have bilateral seizures had a unilateral preponderance and vice versa. So the study kind of emphasizes the importance of long-term ECOG monitoring in accurately being able to detect or determine your seizure lateralization and understanding the dynamics of your seizure activity. Now, the group from UCSF came up with this study, which is a relatively recent study, to estimate the duration, like how long do you need to record to achieve stable estimates of seizure laterality, and how many seizures do you actually need to feel comfortable with that laterality. And they made some recommendations for clinical decision-making. They had about 13 patients in this. They were, again, drug-resistant bitemporal epilepsy, mesial epilepsy, who were implanted for at least 1 year with the RNS system. The study found that you needed an approximately 8 months of chronic ECOG recordings to obtain stable estimates of the seizure laterality ratio. It's important to know that this duration is actually considerably shorter than what was previously suggested. I think the previous recommendations were, recording for a period of 2 years. And it also noted that 75% of these patients achieved that convergence within 1 year or less of the RNS recordings. Now, based on these results, they provided some recommendations, and they basically suggested capturing at least 50 electrographic seizures, monitoring for approximately 8 months to ensure that you have a reasonably good confidence in seizure laterality ratios. They did know that a smaller subset of patients required longer durations, and then you clearly needed like more to identify these patients and why these patients have needed longer durations, and to kind of decipher like the other complexities associated with it. Now, long-term ECOG, as I said, it not only just helps in lateralization, but also helps play a crucial role in identifying potential surgical candidates. Surprisingly, seizure freedom rates have been reported in patients who were initially thought to be ineligible for surgery because of bilateral onsets, but were later identified as resection candidates based on the data from the RNS system. Now, these findings highlight that neuromodulation and surgery don't have to be mutually exclusive, and combining therapy can actually be potentially effective in some patients with independent bilateral seizure onsets, but who show a more of a unilateral preponderance. There's also studies that looked at circadian and I can never say the word, multi-day influences, which play a significant role in seizures and epileptiform discharges. Again, recognizing these patterns is valuable for estimating your probability over time and optimizing your treatment strategies. The graph to the left is actually a study that looked, again, from the UCF sub from Dr. Vikram Rao's group, 134 patients recorded for 84 days. And they found that seizures coming from the mesial temporal regions exhibited more of a biphasic or a diurnal pattern of detections, while the frontal and the neocortical temporal epilepsies had more of a monophasic, nocturnally predominant pattern. Now, to further explore the seizure predictability, they developed a computational model using interictal and ictal data from the RNS system. This model actually successfully predicted seizure occurrence in the subsequent hours or days. In a validation study where they tested this in 157 patients, the model was accurately able to forecast seizures within 24 hours in 66% of the patients and up to 3 days in advance in 39% of these patients. You can see how this can have huge clinical implications. Now, for individuals with epilepsy, I think the unpredictable nature of seizures is usually a pretty significant cause of distress and suffering. This kind of knowledge can help, healthcare providers make medication adjustments, a lifestyle modification, and other interventions to basically reduce a seizure, seizure frequency, basically prevent a seizure from happening and improving the quality of life. We alluded to this earlier. I think there's also like changes in detection counts have been identified as potential biomarkers. Again, you can use all of this to make medication changes in the outpatient setting. There clearly are limitations to this. Patient variability is huge. Sampling bias, we've always talked about this, and also detecting sites of seizure propagation rather than seizure onset and other external confounders. But overall, I think the trends from ECOG serve as useful metrics to determine a response to therapeutic interventions. There's also been studies looking at the use of intracranial data as biomarkers in the field of epilepsy. This is a study from our group. Also, it was a multi-center study, but our group was involved. It looked to investigate differences in network synchronizability between patients who were responders to RNS and those patients who were non-responders to RNS. And the outcomes were measured for a period of 2 years after RNS titration. Now, network synchronizability refers to the degree to which brain networks exhibit a synchronized activity. And there's various different ways you can quantify this. In this studies, again, not going into too much details of it, which I probably won't be able to explain, but what they did was they used computational synchronizability curves with 2 different frequency bands in the beta and the gamma range. I guess the frequency bands were chosen because they are relevant for understanding like neural synchrony and seizure dynamics. The main findings from the study was that patients who responded to RNS, or the RNS responders, or ones who showed a positive response to therapy, they demonstrated a significantly smaller value of network synchronizability. And these trends seem to maintain even after a period of, even after segmenting patients by onset location. Some of the earlier studies have also suggested like a smaller pre-ictal synchronization or synchronizability magnitude was also known to be a hallmark of network focality, again, showing that these patients could also be better responders to RNS treatment compared to the others who are not responders. More recent studies have looked, they've indicated a broadened use with reported seizure reductions targeting your thalamic nuclei in patients with multifocal and generalized epilepsies. I think these case series provide good insights into the potential benefits of RNS stimulation targeting different thalamic nuclei like your central median, pulvinar nucleus in patients, most of them having an average follow-up rates anywhere between 17 months to 2 years. I think it's important to consider, point out that these studies have smaller sample sizes and that research in this field is continuously evolving. But the initial promising results from these have led to the initiation of what the prospective multi-center randomized trial called Nautilus, which is looking to evaluate the safety and effectiveness of thalamic stimulation with the RNS system in patients with idiopathic generalized epilepsy. And hopefully this will again contribute to the growing knowledge of safety and effectiveness in thalamic stimulation. All right, moving on, we're almost coming to the end. We're DBS, again, open loop, approved for use in patients 18 years and older. It was approved in 2018, but much earlier on in Europe. Several different targets have been looked at for DBS stimulation. These include the anterior nucleus of thalamus, central median nucleus, thalamic, subthalamic nucleus, cerebellum, hippocampus. Anterior nucleus, most well studied. It's part of the PAPE circuit. It has extensive thalamocortical projections, and it's known to play a key role in seizure generation and propagation. Sante was the first and the only major multi-center double-blinded study, the results of which were published in 2010. The study design was similar to your RNS trial, where you had a 3-month baseline, a 1-month post-implant, and a 3-month blinded phase. They had a total of 110 patients who were either randomized to the control or the sham group, but you can see clearly at the end of the blinded phase, there was a 40% reduction in seizure frequency in the treatment group compared to 15% reduction in the control group. 70% of these patients, actually 75 of the original 110 patients, remained in the study at 5 years, and the median seizure frequency continued to decline, was noted to be 56% from baseline at 2 years and 69% at 5 years. Now, the long-term results have shown, they've shown a trend for continued improvement in seizure reduction over time. Again, a median reduction of 75% at 7 years. There's been self-reported improvement to severe seizure types like focal tonic bilateral tonic-clonic seizures and focal impaired Rett seizures. And even after 10 years of follow-up, there's been no worsening trends or worsening adverse effects associated with this therapy. Central median nucleus is part of the intralaminar thalamic nuclei, which is involved in attention and arousal. It also has extensive connections with motor and sensory areas like the medial orbitofrontal cortex, anterior insula. Also has subcortical connections to the basal ganglia, where it receives inputs from your reticular activating system and brainstem. Given its relatively larger size, it makes for easier targeting with thalamic interventions. Now, deep brain stimulation targeting the central median has been explored, as you can see from the several studies that have summarized. I'm pretty sure that's not all of it, but I think those were the most that I could gather spanning over 3 decades. And they've reported varying degrees of improvement in seizure frequency. Also important to note, it's a very heterogeneous group of patient population, like Lennox-Gastaut and generalized epilepsy. I've highlighted 2 prospective studies showing a homogeneous population, and they've had some longer follow-ups. The first one is a prospective open label study that looked at central median DBS and reducing the seizure burden in patients who had generalized epilepsy. Again, there was an 80% reduction in generalized seizures, which these findings are pretty consistent with the previous trials. The second one is 20 patients with LGS, and their primary outcome was looking at a reduction in diary recorded seizures and electrographic seizures. And they've shown a trend for improvement or nearly 40 to 50% reduction in seizure frequencies in both their recorded seizures, daily recorded seizures, and the electrographic seizures. Other considerations, this is a retrospective series that looked at the use of deep brain stimulation involving that's targeting both your central median nucleus and the anterior nucleus of the thalamus. They had about 16 patients, children and adults. Among them, they had 11 of the 16 patients had both central median and ANT implantation, and 5 of them just had the central median implantation alone. You can see the median follow-up was roughly 6 years, and they showed a median seizure reduction, again, close to the 50 to 60% reduction in seizures after a DBS implantation. Overall, there did not seem to be a significant difference between either of the groups in reducing your seizure frequency or severity in these heterogeneous patients, but they also noted that there was not a huge impact. There were device-related side effects. Reportedly, like three of these patients had device-related side effects, and 2 of them needed to be intervened upon. But overall, they had suggested it was safe to use both, safe to like target both these nuclei, and resulting in the same number of seizure reduction in these patients. Other targets, exploring the subiculum nucleus, again, smaller numbers in the cases. There's about 6 to 8 patients, again, noted a more than 50% reduction. Some have also noted or discussed the need for the proximity to the subiculum in mesotemporal lobe epilepsies being predictive of better seizure outcomes. This was a very recent case report from Texas exploring pulvinar DBS stimulation, like using closed loop of the pulvinar and the cortex. I think the case had looked at posterior quadrant onset seizures, and they found to have some improvement with it. Again, this is just one case report, and I think we need larger further studies to kind of validate these observations. Quick word on DBS as a closed loop. It's also an emerging approach in the field of neuromodulation. The DBS devices, they have the capability to sense neural signals like local field potentials and use this information to adjust the delivery of stimulation in a closed loop manner. Now, Persyst device with brain sense technology, it allows for the capturing of these local field potentials, and these can be recorded simultaneously while you're delivering therapeutic stimulation. And, this kind of enables for more personalized programming, and you can tailor it to like patient-specific needs. Now, unlike the RNS device, where you can directly visualize the ECOG, now the DBS device is a closed loop, will portray the ECOG data as a spectral power within specific frequency bands. Now, there's a lot of literature that explores like which biomarker is the most effective in like different neurological conditions. For example, in Parkinson's, the DBS device records these local field potentials, and it delivers a stimulation when there is a peak of beta frequencies around 20 hertz, which is where there is thought to be a loss of motor function. But preliminary studies for epilepsy patients have suggested that theta frequency may be more indicative of a nickel pattern in the thalamus. Again, the clinical effects of these brain sensing validation is not fully established, but the results appear to be promising. Dual device neuromodulation, this is probably coming close to my last few slides. Again, there's a few case reports. The rationale behind this is that epilepsy is a network disease. It's pretty complex. And by targeting different sites, we may be able to like modulate like neural targets to provide for a more comprehensive and an effective approach to seizure control. Now, several studies have explored the potential benefits of this. For example, there are studies looking at combining DBS with VNS. The first was looking at 11 patients where you had DBS, central median DBS combined with VNS, showing a combined efficacy of more than 50%. And patients who were actually previous non-responders to VNS had actually showed a better response when DBS was implanted, again, showing a synergistic interaction between the two. Second one was 33 patients looking at DBS, looking at anterior nucleus of DBS with VNS. Again, seizure frequency modest to about 50%, and there was no device-related complications with concomitant VNS and DBS use. Additionally, you also have the combination of VNS with RNS, 2 case reports from our center, where we show that when there was a when we temporarily stopped the VNS or like turned it off, there was a resultant increase in seizures in both of these patients, again, highlighting the benefits of using these and providing additional seizure control and improve outcomes for these patients. All right, and this is my last slide. I think there's a critical unmet need in the treatment of drug-resistant epilepsy to kind of standardize criteria for stratifying our patients to the most appropriate treatment options. We've seen that there are several different therapeutic approaches, surgical approaches for our patients, including laser, neuromodulatory devices, minimally invasive procedures. Some of these newer options have the potential benefits of reduced invasiveness, and they have the ability to modulate your brain activity. But choosing the most suitable treatment requires careful evaluation and comparison of study results and outcome data. And it's also crucial to understand the effectiveness, safety, and long-term outcomes of each of these procedures to make an informed decision. The several treatment algorithms that have been proposed and developed, again, all of these would need customization and personalization specific to each center and clearly specific to every patient characteristics, including the type, seizure frequency, imaging findings, and other comorbidities should all be taken into account when you're determining the best treatment options for these patients. So with that is my last slide. With that, I'll end. Thank you for your patience and your attention. Stop sharing.
Great. Thank you so much. That
That was
a
great.
packed
Yeah,
talk.
definitely.
Yeah, that was full of information. I really enjoyed that. I do understand that you have a hard stop. So just remind me or let me know, how many minutes do you have right now for
We have like
questions?
4 minutes. I mean, if you're not able to get to the questions, I'm happy to like also take it. Like if there are things that can be emailed, I'm happy to send it across or like share the information that I didn't show in the slides today.
Yes, and that is how we'll approach it. So anyone, if you have a question and we don't get to it now in the next 3 minutes now, we will send an email and the answers to your questions will be shared with everyone. I actually had a question way back when you were talking about LIT, which seems like ages ago now. You mentioned that for the mesial temporal lobe epilepsy, the outcomes were comparable between lesional and non-lesional. So my question was, is there standard best practice for targeting or target planning of the non-lesional? I think you mentioned that there were specific anatomical structures that were identified, but apart from that, do you do any subject-specific anatomical planning?
No, that's a great question. And I think I purposely kind of left that out because the literature is kind of debatable. There were some studies that have showed that radiographic evidence of like mesial temporal sclerosis were not impacting seizure outcomes. But clearly some other studies have shown, a modest difference between the two groups, between radiographic and non-radiographic evidence. But there's a lot of literature out there. I think, again, there's, quite a few that have validated like volume ablations of like the mesial temporal structures, particularly to include the parahippocampal gyrus that have shown better outcomes. Like I've said, I think we have not incorporated the two trajectory approach, like targeting all of these sub areas in the mesial temporal structures at our centers, but I'd be curious to hear other people. I guess the long-winded answer to your question, I think that was a long one, but the short-winded answer to your question is, I think, is yes, there is supportive evidence to show like more tissue, like more volume of ablation is better compared to lesser, if that makes sense.
Yeah, that does make sense. Okay, thank you. And then we have a question, is multiple subpial transection still a treatment modality?
I don't know the answer to that question. I know it's been used, I've come across studies that have looked at the usefulness of this in epilepsy patients, like particularly where you have eloquent cortex involvement, where they transect the cortical fibers in the affected area, basically to prevent the spread. But is it still a widely used approach? I'm not entirely sure. We certainly have not done this, or I haven't experienced this when I was training, or certainly in practice as a few years have been at Penn or at the Cleveland Clinic. I guess the decision is kind of made on like a case-by-case basis, I would think.
Yeah, okay, great. Let's see if we can fit one more in here. Dr. Appendino has a question. Hi, Dr. Appendino. Great lecture and a lot of information. Thank you very much. A simple question that I always struggle with to get clear answers: how this long-term effect studies, for example, VNS greater than 10 years follow-up, differentiates efficacy of the devices versus medication, ASM changes. Patients need to be on the same ASM scheme for more than 10 years to really assess the device effectiveness, correct?
Let me see. Long-term affecting studies, VNS for 10 years differentiate the efficacy of devices versus STEM. Patients need to be on scheme for more than 10 years to assess the device. I don't think we know. I think that's a really hard question to answer. Like I said, we don't have head-to-head trials like looking at the devices itself, but we also don't have, I think one of the studies that I actually pointed out was the VNS. I think even after 2 years of therapy, like neither the open or the closed loop stimulation showed that there was a trend where you could actually reduce seizure medications even at the end of the 2 years. But I don't think we have long-term studies to actually answer the second part of your question, to say how long do we really need to be on medications to assess for device effectiveness. I think one of the key things, and I think we also struggle with this in in clinical practice, is to basically say neuromodulation is modulation of epilepsy is a disease over a treatment of time. Like, I find this hard to sell to patients, like compared to like surgeries, because I tell them, like, don't expect an immediate decline in your seizure frequencies. Like, it takes time for these devices to kick in. And it takes time to see the long-term benefits and the potential side effects. Now, how long, like, what is the duration for each of these devices? And I think we had one data from RNS that said, record for at least 8 months and have at least a minimum of 50 seizures before you can kind of make a decision about intervention or tell whether or not this is helping. I don't think we have that data for DBS or VNS. I've had patients go both ways. Again, maybe the implant effect, but I've had patients with, I recently had a central median DBS patient who has been seizure-free for the last 1 year, but another patient, again, heterogeneous patient population, but again, another patient who's not been seizure-free at all. And we're still kind of modulating the parameters. Again, I think the short answer to your question is I don't think we know. Again, it's all like tailored to individual patient population and tailored to individual, etiologies and other things that kind of go into the context of it.
Yeah, that makes sense. That makes sense. Okay, I think you're out of time. So we're gonna stop there. And if there are any other questions that we did not answer, we'll follow up in the email that will also have the link to this recording. So thanks very much, Dr. Raghupathi. That was a fantastic talk.
Thanks.
And yep,
Take
all
care.
right. Look forward
Bye-bye.
to more conversations in the future. Bye-bye.